Okay, welcome everyone to our Brain Tumour Feature Week question and answer session via Brain Translate. My name is Brett Drummond and I'm one of the co-founders of MS Translate and one of the science communicators driving the Brain Translate initiative. We're joined tonight by three fantastic researchers that are part of the Brain Tumour team, and you will have seen some of them already on some of the feature videos that we've been providing this week. So what we're going to be doing tonight is we'll throw over to them to introduce themselves, and then we're going through some of the questions that we've received via the forum. If you are watching live and want to ask any questions, feel free to drop them to us by email or on the Facebook page, and we'll endeavour to ask them as we go along. All right, so without any further ado, I might hand over to you, Kate, if you want to start and introduce yourself, and then we'll go from there.
Hi, I'm Kate Drummond. I'm not related to Brett, who's just introduced himself. I'm a neurosurgeon at Royal Melbourne Hospital, and I specialise in treatment of brain tumours and clinical and some laboratory research into brain tumours.
My name is Rod Gawar. I'm one of the scientists in part of the Department of Surgery here at Royal Melbourne Hospital and University of Melbourne. We specialise in glioblastoma research, so we're looking at markers for survival and also markers for resistance to treatment.
Hi, I'm Andrew Gogos. I'm a neurosurgical trainee and taking time away from my surgical training to do a PhD with these guys, looking at potential new therapeutic pathways in brain tumours.
All right, fantastic. So as I said, we might start by going through some of the questions that we've received on the forum so far. We'll start with a question that we received from DD3D. And their question was, are there any new treatments for astrocytoma?
Well, I think there's lots of things that are being developed for treatment of astrocytoma. I think for the last probably 7 or 8 years, we've really been using the same treatment, a combination of surgery, radiotherapy and chemotherapy. But I think there have been some advances in surgery to make the surgery better and safer, which is one part of new treatments. I think radiotherapy's been improved, and there are so many new agents in trial for astrocytoma. Probably some of them are traditional kind of toxic chemotherapy, but some of them what's now called targeted agents, where as we understand the molecular biology or the genetics of brain cancer more, we can design treatments that target those abnormalities rather than targeting all the cells in the body. So there's lots of treatments in development, but Rod, we want to talk about that a bit as well.
And more than me. Yeah, obviously there's lots of different drugs being used and lots of different drugs trying to be tested. So in terms of astrocytoma, I guess there's quite a few, but the standard treatment is something which maybe I'll handle Andrew. So I've got a few questions. You go.
Yeah, sure. So I think the surgical aspect has improved, as Kate said, with improvements in imaging and particularly while you're in the operation. That is becoming more common. And also using fluorescent markers in theatre. So you can effectively make some tumours glow, which means that you can resect more of it and have decreased chance of harming the in terms of chemotherapy, there are certainly lots of exciting new things that we hope might be of benefit, but they're really in the early trial stages now. And so people with astrocytomas are sort of encouraged to take part in clinical trials, and places like the Royal Melbourne Hospital have oncologists who are heavily involved and know all about all the clinical trials that are in place and can help people get involved in those if that's something they want to do.
Okay. Well, actually, that might segue nicely, and we'll welcome Nicola into the conversation now. She's just joined us, and we'll throw over to her to ask a question in a little while. Just, Nicola, your microphone is muted at the moment, so just make sure that you take that off before you ask any questions. But I'll just segue from that with a question to you, Rod, based on the papers and videos that we filmed with you this week. Do you want to talk about the sort of ways that you're investigating coming up with better treatment options for GBM, and sort of how that study's progressing?
Sorry?
In terms of how that study's progressing and the techniques that you're using to come up with that?
So in terms of techniques, we're using gene expression arrays. So we're using arrays which can measure thousands of genes at the same time. So what we're looking at is archived glioblastoma tissue, and we're looking at differences in genes between all surviving patients. Those are the guys who survive about no more than 6 months, comparing the gene expression profiles of those guys versus patients who live a little bit longer. And we're looking at patients who live out towards sort of 18 to 24 months. What we want to do is find genes that are different with the better surviving patients versus the poor surviving patients. And once we know those genes, we should be able to potentially find drugs that can target those genes or target those proteins. And if we can do that, hopefully we'll be able to prolong the lives of some of these poor surviving patients.
Okay. And that's, I mean, you're looking specifically at GBM. Is that research being done across other types of tumours as well? Similar sort of studies you're aware of?
Within our department it is. I'm mainly focused on GBM, but there's another project going on where we're trying to identify markers that look at patients who have grade 2 tumours which eventually evolve into grade 4, and trying to understand what drives grade 2 turning into grade 4 glioblastoma. So that's looking at not only tumour samples but also serum samples. That's another project we're doing.
Can you pause that? Won't be long.
Okay, all right, fantastic. All right, we also have a new person joined in the conversation at the moment as well. Nicola, I might throw over to you. Do you want to ask, I know you submitted a question via the forum, but seeing as you're with us now as part of the discussion, do you want to ask your question?
Can you hear me now?
Yeah.
Or have I still...
Yeah, no, you're good to go.
Yeah, I actually had a question in relation to neuroplasticity. I'm not sure if you've got there my question, if the others have got the question I had with a bit of background to this.
Mm-hmm.
Would that be the case?
Yeah, we do have it in front of us. So this is for you guys. This is question 5.
Yep.
I'm on it.
Yeah. So just quickly, I've been living with an...
Oh, I think Nicola's connection may have just dropped out again. She's just in Melbourne at the moment, actually, down here from Canberra and in a hotel. So I think the connection may be playing up. So I'll read out the question that she submitted. So she's asked, what do you think about the emerging science of neuroplasticity and whether it offers hope and can be of value to those of us with deficits resulting from brain tumours? And she has visual, spatial and cognitive deficits from an oligodendroglioma in a parietal lobe that was diagnosed and radiated 15 years ago and partially resected 12 months ago. You can see some further information there as well. But, you know, comment on the first part of her question?
Well, I think we know that there is neuroplasticity. I mean, we know that children who lose large functional areas of their brain do eventually regain some of those functions. And I think we know from some of the articles on cortical stimulation. So patients who've had 1 or more surgeries for a brain tumour, areas where function was found by direct electrical stimulation of the brain in the first surgery can have changed in the second surgery. So we do know that the brain can shift around functions and that there is sort of, we know there is neuroplasticity. I think the thing that we don't know is how to predict if it will happen and how to make it happen if we want it to happen. So I think it's probably an understudied area. I think the big problem is that it's easier to kind of research that in a trauma concept where there's a single event and then you can see how the brain recovers. The problem with with the brain tumour situation is that it's a dynamic event. The tumour is always changing or being treated or growing or being removed. So it's very hard to kind of get an overview of exactly how the brain's responding to that.
Yeah. Okay.
Well, I'd say that aside from potential research into rehab and sort of physiotherapy techniques that can improve people's function with the deficits that they've got. So I think it's important that if you do have spatial or cognitive problems, there are certain sometimes help with a rehabilitation doctor can help develop strategies to deal with those problems. Can be just as important.
Okay. Now, Grey Matters, we have you as part of the call. Do you have a question? We can't see you at the moment. Do you have a question that you'd like to ask anyone?
Oh, not at the moment.
Not at the
Sorry,
moment?
I'm late. Yeah, I apologise
No, no.
for the lateness. Technology baffling for me.
Okay, no, you're fine. Well, we'll keep going. We'll ask another one of the questions off the forum then. And this question came to us from Julia Robb. Which is the better surgery for resection of third ventricular tumours in terms of post-op side effects and in terms of risk?
Well, that's probably an unanswered in that there's a whole 3-inch thick book on my shelf about surgery of third ventricular tumours, and I actually can't answer it unless I knew the exact site of the tumour, the size of the tumour, the type of tumour that it was, what the goals of treatment were, whether you were trying to remove the whole thing or whether you were just apart. There are multiple approaches to the third ventricle, and there are multiple different kinds of tumours that can reside there. So it's a little bit of an unanswerable question. It's one of those discussions that if you're going to have that discussion with the patient, you need to know everything about their scan and their tumour and everything about them, so that you can sort of choose what the right approach is. So there's not a general answer to that question.
Okay. Well, she also asked another question. What kind of impact can ventricular tumours have on speech and vocalisation?
Well, I presume we're still talking about third ventricular tumours. So, I mean, the third ventricle is right in the middle of the brain, and so it can affect a lot of things that might sound like speech, in terms of memory, but also if it's very large and it affects the temporal lobe, it's a little bit far from kind of what we'd normally consider to be speech areas, but certainly if it got very large, it could affect speech and vocalisation. And of course, if it was approached through that area for a surgical approach, that could also affect speech. But it's very hard to, it's hard to sort of predict without knowing exactly what sort of tumour you're really talking about.
Okay. All right, thanks for that. Well, I might just segue from that into, I know in your intro video, Kate, that you did at the start of the feature week, you talked about the different areas of research that the research groups were looking into, and one was looking at improved surgical techniques and taking techniques that have been developed overseas and trying to implement them here in Australia in an Australian setting. Can you elaborate on that anymore?
Well, I think there's sort of 3 main things that we would really talk about. It would first be something that Andrew's already spoken about, which is fluorescence-assisted resection of a brain tumour. So for those high-grade tumours, glioblastoma multiforme, anaplastic astrocytoma, probably a few others, giving the patient some dye to drink before the operation, and then using a blue light to be able to see exactly what's tumour and what's not tumour, because the tumour glows red under the blue light, is something that's been really almost standard of care in Europe and the UK now, and really has been shown to remove more tumour safely. Now we're not talking about a surgical cure here, because surgery is not going to cure these patients, but we do know that removing more tumour can prolong survival. So that would be the first technique. I think the second one, which maybe actually will be partly relevant to high-grade tumours, but also to lots of other kinds of brain tumours, particularly the slow-growing or low-grade astrocytomas and oligodendrogliomas, will be intraoperative imaging. So we're building right now an intraoperative MRI scanner. So we can really, while we're doing the surgery, put the patient in the MRI scanner to determine whether we've removed as much tumour as is safely possible. And that's going to be a big difference to the way we do surgery for these kind of tumours. And we're hoping that that'll be operational in February next year. So that will be a big difference. And then I think the third thing is really an old idea, the idea of operating on a patient under local anaesthetic. But it's really become, but it's a real resurgence of the idea that you can, if a tumour's in an area that might cause harm to the patient with its removal, you can minimise that harm by doing the surgery with them under local anaesthetic, so that you can, and with some sedation obviously to make people comfortable, so that you can stimulate the surface of the brain electrically to work out where function is, and also test the patient during the removal of the tumour, so you can make sure that function is being preserved and stop very quickly if you get even the slightest, say, weakness or trouble with talking or whatever. And I think they're the three main things that are really sort of changing brain tumour surgery. I guess the other thing is really the combination of therapies, and it's a little more relevant for some of the difficult to remove benign tumours, something we call skull-based tumours, but meningiomas or acoustic neuromas that can often be cured with surgery, but the side effects of the surgery can be quite high. And I think using complex imaging, complex MRIs and computer planning to use a combination of surgery and high-dose radiotherapy almost simultaneously, very soon, one after another, to treat the tumour will be something that will be making real in the next probably year or so.
All right, well, we'll go to another question, actually from Julia again. How effective could the Connexin 46 research be in the long term? Could it be able to not only reduce the tumour stem cells, but perhaps starving it altogether, resulting in a death of cancer stem cells? I know there is a long way to go, but I'm encouraged by the new research coming out and the options we will have in the near future.
This was probably one of Andrew Morokoff's projects, so we'll have to answer it as best we can because Andrew's not here. But for memory, what it actually does is it causes leakiness or changes to blood vessels, and what the ultimate aim there is basically to be able to make the tumour itself weaker by reducing blood vessel stimulation. So nutrients coming through the blood vessels are reduced, and so the tumour should be able to be a little bit weaker in terms of being able to proliferate and divide, and obviously migrate and invade. So in terms of reducing cancer stem cells, it should be able to, if this idea is correct, it should be able to reduce the number of cancer stem cells and inhibit those cells and eventually kill them. So that's the ultimate goal of this particular research Andrew Morokoff's driving.
I think a lot of our research here is focusing on cancer stem cells. Maybe we should explain what they are. So the idea here is that we don't have to target the entire tumour, but there's a smaller population within it that are driving the rest of the growth of the tumour. If we can find specific things to target there, then we may be able to, after resecting as much of the tumour as we can and using conventional therapies, be able to remove that small population that is responsible for the regrowth of the tumour. And so that's the idea behind that project. And it's a different way to approach cancer research, but it's certainly in the early stages. And this is things that we're doing in cells under the microscope, and it's unfortunately a long way from patients in clinic at the moment, but that's where we're hoping for it to end up.
Okay. Well, I mean, in a lot of the research that we've talked about this week, we talk about migration, invasion, and growth as, I guess, three things that we're looking at trying to stop. Which of those are current therapies really looking at, and which is probably the main target of ones for the future? Is there any one more than the other that we're looking at trying to stop?
I guess they go hand in hand. A lot of the growth factor inhibitors or growth factor receptor inhibitors can do all. So a perfect example in GBM is EGF receptor, or epidermal growth factor receptor. That receptor is known to be able to help cells proliferate, but also help cells migrate and invade. So the idea behind targeting that particular receptor is that, one, you can stop the tumour from growing if you can block that receptor, and that receptor is actually important in driving tumour growth. But at the same time, the same signalling that it's driving in the cell will also block the cell's ability to migrate and invade. So a lot of drugs can actually do all at the same time.
I think it's kind of unfortunate that most of the effective treatments we have, and everyone's focusing on targeted therapies, but the reality is, in fact, the most effective treatments that we have at the moment are simple agents that actually damage cells and just kill them. And so growth is probably the target that we have that's most effective at the moment. So radiation and the chemotherapies that we use are basically DNA damaging agents, and they just, when the cell divides, the cell dies because the DNA is damaged. So growth is really, unfortunately, our target at the moment. There have been, however, trials of various agents that would target all of those things. Just in the last 5 years, there's been integrin inhibitors, which were really hoping to target invasion as well as growth, and there have been lots of targeted pathway inhibitors that should affect all of those areas. But at the moment, most of what is in trial has been, unfortunately, less than what we hoped for.
Okay. Well, that probably segues into another question that we have here, which is how progressed is the 5-year quality of life project, and are there other projects that people can be involved in, and if so, how do they register?
So the 5-year quality of life project is going fantastic. So we've got 2 years of data now, with over 400, almost 500 patient responses. It's a pretty simple project in that we just do the same standardised quality of life questionnaire on all of the patients who attend our clinic on every occasion that they attend. And sometimes that might be once a year for, say, follow-up of some of the benign tumours, the meningiomas and the acoustic neuromas, and sometimes it might be every 3 months for some of the low-grade glioma patients. And we've got some early interesting data about that the quality of life of the brain tumour patients that we've tested is probably not so bad, in fact, compared to a lot of other diseases, which has been very interesting. But we've also identified some areas that really are major contributors to the decrease in quality of life that the brain tumour patients have. And that's a little bit tumour specific, but say for patients with low-grade gliomas or the astrocytomas or oligodendrogliomas, we've found that fatigue is really a major problem, and also an idea of cognitive deficit, that the brain is not working quite so well. Although the next phase of the research, which sort of will happen in the 3rd year of data collection, often that feeling that the brain's not working so well is not detected by testing that the brain's not working so well. So it may be almost more an emotional or fatigue kind of thing, rather than that the brain can't function. It just feels like it can't function. So there's some interesting things to tease out there, and I think the important thing that will come from that will be, well, what actually is it useful to do to try and improve people's quality of life? We kind of think that we maybe should have a support group or a this or a that or whatever, that would be helpful for the patients, but we can't really sort of say, well, actually, the best thing we could do is to have specialist occupational therapists and physiotherapists who can help with fatigue management, or maybe even drug therapy for fatigue management. Or, you know, if people feel that their brain isn't working that well, should we do a battery of tests that work out how we could target that? Is it that their brain's not working well, or is it actually that there's some other problem that we could deal with? Like, it might be depression, it might be fatigue, it might just be anxiety, that what if the tumour's growing back and that's sort of clouding their thinking. So I think the project's going well in that we're collecting data, we're collecting masses of data, and now really it's sort of going through it. And each year as we tick over, we've got a slightly different focus depending on what the results were from the year before. So it's a work in progress, but really interesting work.
Okay. And are there any other trials ongoing at the moment, or trials that are upcoming that people can be involved in?
We've always got clinical trials running. So we've got, and really, it's a bit of a Victoria-wide approach. It's a small community who treat brain tumours. So we'll have a trial running, and the Austin Hospital will have a slightly different trial running, and we'll cross-refer patients depending on, you know, who fits for what trial. So there are some trials currently running for recurrent glioblastoma, so glioblastoma that's already had standard treatment and has grown back, and most of those are around what Rod already mentioned, the EGFR, the EGF receptor, either being used as a target or being what's the word? Sort of guide chemotherapy towards the cell, or being actually used as a target to kill the cell. I think there'll be the next big thing will be the IDH1 inhibitor trials, which are in phase 1 overseas, and I'm hoping that they might come here. We've just closed a PI3 kinase inhibitor trial, so there's always things coming up. And I noticed that there's an electromagnetic sort of ring around the head trial running at St Vincent's at the moment. So there are always trials running. It's a matter of you know, us matching the patients with the right trial, because of course the trials are very restrictive as to, you know, who can get in. They have to be to get appropriate results.
Okay. All right. And so is there a way that people can find out about all the different trials, or this will just be as they're seeing their
I think the first port of call, as I said, for brain tumours, it's a pretty small community. So I think speaking to the oncologist that's treating them, pretty much all the oncologists, specialist oncologists who are treating brain tumours will be able to tell you which trials are running. There's not that many across town. If you're in a rural area, then I'd say, you know, and it may be that's not quite so it's not quite so visible to oncologists in rural areas, although of course we liaise with them constantly. Then you know, just get an appointment at Royal Melbourne or one of the other big brain tumour centres and come and see what's running, and you know, we can at least advise you if there's a trial open, and we're always happy to see people in the clinic to look for their suitability.
Okay, all right, well, we'll just, Grey Matters, do you have any last questions that you'd like to ask?
Just quickly, Kate, could you shed some light on the trial about the targeting protein in tumours that Royal Melbourne's doing?
Not quite sure which one you're talking about.
Yeah, I don't know what it's properly called. All I know is it's targeting the protein in tumours. Yeah, so sorry, I don't know anything more than that.
Well, there are a few. I don't know if you're thinking about the one at the Austin, which uses EGFR to take a chemotherapy to the tumour, an antibody with a chemotherapy attached, and that, you know, that's an ongoing trial. And there's a couple of other ones we're running here. We've got a targeted agent against FGFR, which is another growth factor in glioblastoma. It's only actually present in 5% of glioblastomas, so we're screening everyone to look to see if they've got it, but it's only, you know, sort of being really available to a very small number of patients. I mean, other targeted agents that we have used has been the Avastin, that for recurrent glioblastoma, that's a targeted agent against VEGF, but that's closed at the moment. And you might be thinking about the PI3 kinase, which is one of the growth pathways, probably also invasion pathways. That there was a targeted agent for that, but that's just closed as well. Is that helpful?
Yeah, that's helpful. That's great. Yep. And I just want to say this is a really good forum, and I just want to touch base very quickly on your issue about the Quality of Life project with fatigue and cognitive deficits. And because a lot of us brain tumour patients, we look all right when you look at us, but yeah, so we do have a bit of issues with the fatigue and the cognitive stuff. And if we could get some access to OTs, that would be great. Like to get some assistance, that'd be good.
That's what we're building the data for. You know, so that when we kind of go to the people who have to give us money to pay these people, we've got hard data to say, you know, well, here's what we found, and this would be the most useful thing that you could do.
Yep, absolutely. It's great. Yep.
Okay.
Yep. Thank you.
Oh, might just need to mute you at the moment because we're getting feedback. All right, well, on that note, we might bring the question and answer session to a close. I don't know if you guys have any final comments that you'd like to make on anything. No?
I guess that there was one question here that we didn't answer about the familial link with GBM.
Yeah.
Mm-hmm.
That's actually exceptionally rare, but there is a big Australia-wide study called the AGOG study, Australian Glioma Outcome, Genomics and Outcomes, anyway, the AGOG study, where both people with any sort of glioma and their family, a family member, are being extensively genetically profiled, but also a big environmental history being taken with all of the risk factors for tumours to try and get an idea of the interplay of genetics and other things in our environment. So there is a big Australia-wide study. I think there's about 400 patients in that now, so that is an area of interest.
Okay. All right, well, just leaves me to thank everyone for their participation tonight. It probably doesn't come as a surprise to anyone that these guys have extremely busy schedules that they've taken time out of to come and talk to us tonight. So thank you all for your time and participation across the whole week. For our participants, Nicola and Grey Matters, thanks for joining us and asking your questions. For our participants on the forum, thank you for sending your questions in as well. Hopefully you found this useful. The forum will continue, so feel free to send any questions that you have that have come up as part of the discussion tonight, and we'll try and get back to those as soon as we can. All right, thanks everyone for your participation, and we'll talk soon.
Thank you.
Thanks.
Thank you.
Bye.
Bye.